Hi everyone, my name is Stacey Fisher. I'm a postdoctoral fellow with the Data School of Public Health at the University of Toronto, and today I want to tell you about the work our team is doing developing population health prediction risk algorithms using machine learning methods. Data from population health surveys, administrative health records, and environmental monitoring are increasingly being linked at the individual level. This large, complex population level data has brought with it opportunities for machine learning to improve public health. Just as AI has led to the advent of precision medicine, it also has the potential to facilitate improved identification of high risk groups and targeting of population health interventions to populations that are most in need. Known as precision public health, AI can be used to inform how the right intervention can be targeted to the right population at the right time. In this presentation, I'm going to describe how our team is developing predictive risk algorithms designed specifically for population health planning purposes, using machine learning methods. Due to COVID-related data access issues, this presentation will be more of a protocol presentation than we had planned, so I'll be focusing on the considerations we are making to ensure that the algorithms will be appropriate for health planning purposes. We'll start with a brief overview of how these algorithms are used, then we'll move on to transparency, data and variable considerations, model development and imbalanced data, and the evaluation of model performance. Let's start with some context about how predictive risk algorithms can be used for population health, for description, projection, and evaluation. Most simply, description involves assessing the baseline risk of disease in the population. It is important to understand what the average risk of disease is in the population, how it is changing over time, as well as how risk varies across policy-relevant population subgroups. These models can also be used for projection. Projection involves predicting future incidence of disease. Projections developed using these models can produce estimates that are more accurate than those produced by more commonly used methods, as baseline risk factor characteristics are directly incorporated into the model. Therefore, they can also be used to estimate the contribution of behavioral risk factors to disease incidence. Lastly, we have evaluation. Predictive risk algorithms developed for use in the population setting can be used to estimate the potential benefit of health interventions or risk factor reduction. Machine learning methods have the potential to help improve these population health planning tasks. They can produce improved estimates of disease incidence and burden to inform resource allocation decisions. Prediction of risk at finer geographic and temporal resolution using more detailed data can facilitate the identification of at-risk population groups and improve targeting of public health interventions. And ultimately, this may lead to improved identification and reduction of health inequities by incorporating broader social and environmental determinants of health into planning decisions. One of the larger themes of this work that we are being sure to emphasize is transparency. One of the biggest challenges with the use of machine learning methods is that the modeling process is often inherently uninterpretable. So although I would argue that transparency is important and should be prioritized in the development of all models, it is especially important when using machine learning methods. Transparency enhances reproducibility, is important for assessment of validity and algorithm generalizability, and it's important for increasing confidence in decision-making that uses the model outputs. So we will be publishing our study protocol where we fully pre-specified the analytic plan. We're following tripod reporting guidelines, and we will be developing open source machine-readable files to facilitate use of the algorithm by others. We are currently working on algorithms to predict dementia, premature mortality, and avoidable hospitalizations. For this presentation, I'll be largely focusing on the dementia model. The study population consists of Ontario respondents of the Canadian Community Health Survey, a national cross-sectional survey developed by Statistics Canada. This data is linked to the Ontario Marginalization Index as well as administrative health data. Dementia occurrence is ascertained using a validated definition for physician-diagnosed dementia using hospital records, physician claims, and drug dispensing data. We have about 32,000 survey respondents 55 years of age. Now, what's important to point out is that all of this data is population-based. Use of population-level data is important when developing models designed to be used at the population level. Here are some of the predictive variables that we are including in the models. It's important to include variables that are predictive of dementia, but for algorithms that are going to be used for population health planning purposes, you also want to make sure to include variables that are important to public health planners, like sociodemographic variables and health behaviors. We also want to take advantage of geographic information, so we also have included area-level measures, including virality and different measures of deprivation. We are going to be using supervised learning methods to develop these models. So neural networks work well at modeling nonlinear relationships and recognizing higher-order relationships among variables. So these models may work particularly well for dementia, as risk increases dramatically with age. Support vector machines are a very robust modeling approach that are easy to tune and have been found to produce well-performing models in similar contexts. For development of gradient boosting decision trees, we will be using the popular XGBoost, which is a robust and fast algorithm that is capable of handling many features and observations and has also been found to perform well in similar contexts. We will compare these models to penalized logistic regression. As we are including so many variables, penalization is necessary to help avoid overfitting. We will be using nested cross-validation. So our data will be split into training and test data temporally. So model development will be performed on CCHS data from 2001 to 2010, and the models will be tested on data from 2011 to 2014. K-fold cross-validation within the training data will be used to optimize our hyperparameter selection, and then the model will be evaluated on the test data. One specific thing I wanted to mention is that we will not be reweighting the data, as this would distort the population level nature, which is a really important attribute that we need to preserve. So let's talk about this more. Imbalanced data refers to a data set where the outcome variable of interest is skewed, such that it occurs in a small proportion of the study observations. This situation is super common in disease prediction. Most machine learning algorithms were designed with the assumption that the data is balanced. Analysis performed on an imbalanced data set can therefore have poor performance. So imbalanced data is often corrected for in the computer science literature, using undersampling of the majority class or oversampling of the minority class. This, however, distorts the population level nature of the data, which is super important when the algorithm is going to be used for population health purposes. So this is not recommended. However, because we have a large number of predictor variables, and since we are predicting the risk of the outcomes and not classifying individuals as having or not having the disease, and as well considering that we're interested in model calibration and not just discrimination, which I'll get to in a second, we do not expect that the class imbalance of our data will be a big issue. Model performance will be assessed using measures of calibration and discrimination. Discrimination using the C-statistic, and calibration by evaluating the observed versus predicted risks. For example, here we have the discrimination and calibration plots for a dementia prediction model I developed using traditional statistical methods. The concordance statistic quantifies how good an algorithm is at distinguishing between people at high and low risk. The C-stat in both the male and female models is 0.83, which means that most of the time, the risk predictions for people who end up experiencing the outcome are higher than the predictions for those who do not. What's especially important when evaluating predictive algorithms designed for population use, however, is calibration. In the plot here, we see that the predicted risk of dementia, according to the model, compared to the observed risk of dementia in deciles of predicted risk. If all the points were on the 45-degree line, this would indicate that the predicted and observed risks are the same and we'd have perfect calibration. The predicted risk would perfectly align with the observed risk. Risk algorithms for population health should generally prioritize calibration over discrimination due to implications for resource allocation decisions. It's also important, however, to assess calibration across population subgroups to evaluate how well the model performs across these groups and inform model use, but also to help prevent propagating underlying bias in the data or exacerbating existing health inequities. So here are some of the observed versus predicted plots for the same dementia model I developed previously. The bars represent the observed risk in the subgroup, and the X represents the predicted risk in these groups. We can see that the model underestimates risks in older age groups, which can be a problem when predicting dementia. It also underestimates risk in those who have had a stroke and in those with epilepsy. Here we have more observed versus predicted plots by health behaviors and sociodemographic variables. Overall, calibration is okay, but there's room for improvement, which we hope to achieve in our machine learning model. There are many different challenges in the development and use of population-level prediction algorithms. One I want to particularly point out that's related to evaluation of calibration across subgroups is bias. Maybe some of you saw this article when it came out last year. An algorithm used in a US hospital to allocate care resources was found to have significant racial bias. They found that among Black patients and white patients who were equally sick, Black patients had lower risk scores and were therefore less likely to receive additional services. This bias arose because the algorithm was designed to predict healthcare costs rather than illness, but unequal access to care meant that less money was being spent caring for Black patients than white patients. So this is really important to remember that our data reflects existing biases. And just because the algorithm doesn't include a variable in the model doesn't mean it can't be biased on that variable due to correlations in the data. So again, this underlines why it is really important to look at calibration across important subgroups. Machine learning has the potential to produce improved risk prediction models for population health planning purposes. A few things that need to be emphasized, though, is that transparency needs to be prioritized, population level data needs to be used, unbalanced data should not be reweighted, and calibration across subgroups should be assessed. Thank you so much for listening.